mind when you do ask questions, etc. Because we're going to be putting this online. So if you do miss something, have a check on our website and it should be ready there. Okay, so Christine, are you ready? I'm going to pass it on to you. Good.
Yes,
okay.
I'm ready.
Brilliant. Okay, just bear with us a second. There's a small delay in this, so.
Right.
Okay. All right. It should be going over to you now.
Looks like it. I'm just about to share my desktop. And with any luck, I think we should be there.
Great. Okay, okay, I'll hand over the floor to you then.
Thank you very much, Professor, for your kind introduction. That's great. Well, good morning, everyone. I hope you can all hear me clearly. I'm a bit croaky this morning because I've had a dreadful cold, so please forgive the odd cough and sniffle. As Dipan has said, this session is sponsored by Almiral UK, and we're all very grateful to them for their support on this. During the next 35 minutes or so, I want to talk to you about dry skin and getting the best out of emollients. This is a big topic, so I can only cover some of the highlights, but I'll try to focus on the points that I think will be useful to you. This is an area where you can do an enormous amount to help patients, and I hope when I've explained my view of this, you'll find it as rewarding an area as I do. So what I want to do today is explain about dry skin and effective emollient use. I'll be emphasizing that word. I want to help you advise patients with dry skin, and I want to highlight some of the situations that you might refer to the pharmacist for prescription intervention medicines use reviews. First of all, why does dry skin matter? I guess you know the answer to this, but let me give you some of my answers. Dry skin is common. In surveys, 50% of people claim to have dry skin. That's easily irritated or dried skin. Dry skin, as you know, is a feature of skin diseases like eczema, psoriasis, ichthyosis, and it can also be a feature of systemic diseases. It affects all age groups, and men and women. Most importantly, it causes discomfort, distress, embarrassment, and impaired function, as we will see. And even more importantly, many people self-treat and seek advice from pharmacies. So, plenty of reasons for being interested. I would argue that the management of dry skin is a really important role for community pharmacy. Incidentally, you might be amazed that many people are unaware of how to choose and use emollients effectively, and when they get the right one, they are amazed at the difference that it can make. So I think pharmacies can educate people about the causes and prevention of dry skin, and that's what we'll be talking about today, explain the role of emollient treatment, advise on the choice of emollients, and explain how to use them effectively, and also explain how emollients work alongside other prescribed treatment if indeed the patient is having prescribed treatment. Now, I'm trying to move on to my next slide, and for some reason it won't do it.
Try clicking on the PowerPoint presentation itself and pressing the mouse button down.
Oh,
there you go.
I've got the next one. Thank you.
No problem.
Now, here comes the science bit, a bit about skin itself. This is the epidermis. This diagram shows you just the top layer of skin. You can see it's the top layer because there are no blood vessels or sweat glands or whatever. And many of us were told that there's not much happening up here, but in fact there's a lot happening. Let me just take you through the diagram. Down here at the bottom, you have the basal layer. These cells are actively dividing and making new skin cells. Skin cells from here gradually migrate up to the surface, but in doing so they go through the so-called spiny layer here. It's called spiny because in the microscope, under the microscope, you can see little spikes sticking out of the cells. Then there's the granular layer, this one shown in green here. You can't see it on this diagram, but under the microscope they have little dots in them, little granules. This layer, the clear layer, only occurs in thick areas, the palms and soles. So for most of the skin there are just 4 layers: basal layer, spiny layer, granular layer, and this layer at the top, the stratum corneum, the horny layer so-called. you'll notice the cells up here no longer have nuclei. I was told when I was trained these are just dead cells waiting to fall off. In fact, we now know this is a really important area. I'll go on the next slide to explain a little bit about why. This is where the so-called skin barrier or epidermal barrier resides. I'll explain a bit more about this. If I can move, here we go. The epidermal barrier, we now know, is tremendously important. It limits water loss from the skin, and it prevents other things from getting in, things like allergens, irritants, microorganisms, and so forth. Now, what makes up the skin barrier? Well, all those cells, those layers on the top. First of all, the cells are tightly packed together. Secondly, they're actually physically tied together by protein bridges called corneodermosomes. So they're not just sitting there like a load of dead stuff. They're actually tied together, tightly packed, and even more important, they're covered in natural oils. You can think of this a bit like bricks and mortar, if you like. The cells are like the bricks, and the natural oils are like the mortar. It completely coats them and mats them together. The thing that helps the cells stay swollen is a thing called natural moisturizing factor. This is inside the cells, and we know it's a mixture of compounds that holds water and keeps the cells swollen so they're tightly packed together. These factors all together constitute what we call the skin barrier. And we know the skin barrier is important. We know it's weakened or damaged in diseased skin and up to a point in dry skin. So everything we do is designed to restore or improve the skin barrier. Now let's look at some of the things that can damage the skin barrier, and these will be very familiar to you. This next diagram shows you a diagrammatic version. If we take the pink blob in the middle and call that impaired barrier function, for a start, that can occur because of genetic factors. There are all sorts of these, but what you'll know as a patient is that your skin is just a bit more sensitive. It dries out more easily than others, or is more sensitive to damaging things in the environment. And what are damaging things in the environment? Well, all of these. I'll deal with frequency of washing and use of soap products first. If you wash your hands very frequently with soap or detergent, you quickly notice the skin drying. This is because soaps and detergents remove oils from the skin. A dry environment can also make it difficult to keep the skin well hydrated, and I hope by now you're getting the idea that water plays a very important role in the skin. Keeping it in is one of the important functions of the skin barrier. So if you already have a genetic weakness of some sort, and your skin is subject to a lot of environmental influences that will dry it out further, you can end up with impaired barrier function, increased water loss from the skin, more water going out, and when more water leaves the skin, the barrier is weakened. In fact, we know that the cells shrink, gaps open up, and irritants and allergens can penetrate the skin. For these reasons, eczema, I've just put this up here, eczema is sometimes described as a gene-environment interaction. You already have the weakness once you're subject to extreme environmental conditions, or perhaps not so extreme, just a lot of washing and detergents can actually trigger an attack. So, we've seen the barrier is important. It can be damaged by a lot of everyday things. Successful treatment of dry skin depends on correct treatment of the underlying condition, if it's eczema, say, and effective use of emollients or moisturizers. But this element is often overlooked and leads to treatment failure. Treatment with emollients can fail because patients don't use enough, don't use them frequently enough, don't use the most appropriate one, undo the benefits of emollients by using inappropriate wash products. I'll come back to this later. Or they don't get the expected improvement because they're not using them properly and they stop using them regularly, and you can see that quickly leads to a downward spiral. Incidentally, for someone on prescribed treatment, Any of these could be triggers for an opportunistic or prescription intervention medicines use review. So, moving on. How do you know skin is dry? What kind of things are people going to say about their skin that will alert you to the fact? Well, many times, of course, they're just going to come in and say they've got dry skin. But here are a few other signs and symptoms that are worth looking for. People with dry skin will complain of tightness, not just after washing their face, but after washing their body. Sometimes dry skin can be so tight that it's difficult to flex the fingers or the ankles properly. There's also loss of plumpness. Dry skin looks shrunken and dried out. Very often it looks and feels rough and there's fine flaking or scaling. I think we're probably all familiar with this. Worst of all, dry skin often itches. And you all know itching leads to scratching, which leads to more itching and more scratching, and in no time at all you've got quite substantial skin damage. It's very difficult to resist the temptation to scratch. So fine lines or cracks can appear. Redness is often the result of itching or inflammation in eczema. And sometimes badly dried skin can fissure, that's to say form deep cracks, especially around the joints. And these can bleed and make life incredibly difficult. You know, if your skin on your fingers is cracking, it's hard to wash, cook, clean, look after children, or handle manual work of any sort. It can be really uncomfortable. Dry skin, as I mentioned earlier, occurs in a number of skin diseases, eczema, psoriasis, ichthyosis, for example, but also this condition that many people would claim to have, sensitive skin. I say claim to have, but it's a real thing. Some people's skin really is more sensitive than others. Dry skin also occurs in systemic diseases and be caused by some drug treatment. We don't have time to go into these today. Just to remind you, atopic eczema, the eczema that's associated with hay fever and allergic rhinitis, often affects the skin folds. This is the inside of somebody's elbows. And you can see, it's hard to say exactly where it begins and ends. It's obviously been scratched a bit. I can tell you, that's pretty uncomfortable and it makes you pretty miserable. In very young children, almost any area can be affected, even the top of the head like this here. And that's very distressing for parents. Of course, it's distressing for the child too. As I said earlier on, dry skin doesn't just affect children and young adults, it also affects older adults. This is skin in elderly people. This is so-called eczema craquelée or asteatotic eczema. The name doesn't matter. What I think you probably all know is that older people have a thinner layer of fat under their skin, and sometimes the skin can be very delicate and easily damaged. And here you can see this is thin skin, which can be scratched or has been scratched and could very easily be damaged. It's dry and sensitive. And although it most commonly occurs on the legs, this picture on the right is to remind you that it can affect the rest of the body. And this is going to be sore, itchy and delicate and needs careful handling. So, dry skin affects all age groups. Sensitive skin, as I mentioned earlier, 50% of the population claims to have it. They will report burning, stinging or itching after using soap, some bubble baths, some cosmetics. Many have had eczema in childhood, but many have not. And it can be associated with diabetes and aging, but it doesn't have to be. It's a real phenomenon. Now let me move on to emollients. All emollients do the same thing. The problem is some emollients are very much better at it than others. All emollients will form a film of oil or lipid over the skin and trap water in that surface layer that we talked about. They just reduce the amount of water that's transferred and evaporated off it. They also replace the missing natural oils that might have been removed by contact with solvents or a lot of washing with soap or detergents. And they restore and maintain the pliability of skin. One of the delightful things about skin is that It seems so delicate, and yet it does such a strong job, and it remains springy and pliable. When it isn't springy and pliable, that's when we notice it. Emollients also have steroid-sparing effects. There'll be more time to go into this in the workshops in the autumn. But these three at the top are perhaps the really critical things that every emollient will do, but some will do it much better than others. Now, you all know there are problems with emollients. They wear off, they get washed off, people don't put enough on, people don't apply sufficiently frequently. And I'm often asked, what makes a good emollient? Well, I would say these things. First of all, it must have sufficient lipid, sufficient oil, or grease if you prefer the word, in it to do the job, to make that film over the surface that will reduce water loss. I would argue that good emollients always have a humectant in as well, and I'll come on to this on the next slide. Generally, a good emollient is unperfumed, and I say that just because we know that many perfume ingredients can also be allergens, can cause skin irritation. But it needs to have a pleasant smell. If I'm going to use an emollient, I'm going to smell it all day long, so it needs to be a smell that will suit me. And not one that will annoy me. I would say a good emollient needs to have good spreadability, because if I have to rub it in, that might start my skin off itching again, and that's always the beginning of a problem for dry skin or eczema. I'd prefer it to be something that doesn't leave the skin feeling sticky. Many patients tell me this, especially if you work in an office, say, you don't want to be the only one in the office who leaves fingerprints on the phone and grease marks on paper. And finally, what makes a good emollient? Well, it's the one that the patient likes and will use. There's nothing more expensive than the emollient that's left on the shelf. Let me come back to humectants that I mentioned a couple of minutes back. Humectants are substances that attract and hold water. Common examples are urea, which is actually found in the skin anyway, glycerin, propylene glycol, and there are a number of others that are commonly used in emollients. A humectant-containing emollient will do two things. It will reduce water loss from the skin by putting that layer over the surface, as I described, but it will also pull water into the skin. So if you like, you've got the two effects. And humectants pull water into the skin from the dermis below. So you get a longer lasting emollient effect, and you get that without putting a thicker layer of oil or grease on the surface. I really like emollients that contain humectants. A quick word about aqueous cream. Well, there's only one word really, avoid. Aqueous cream is used in enormous quantities, but it's a very primitive formulation. There are two problems with it. It has a very low proportion of lipid, so it really cannot do the job of holding water in terribly well. Second problem is that it contains 1% sodium lauryl sulfate. This, as you will know, is the emulsifying agent that is used, but it's an anionic surfactant, and it's actually very damaging to skin cells. We know this because for years patients have told us it stings when it's put on. Children particularly have complained about this. We now know from recent research that application of aqueous cream actually reduces stratum corneum thickness, reduces the horny layer thickness, and increases water loss from the skin. Also, we know in patients with eczema, atopic eczema, it increases inflammation and increases the rate of skin shedding. So, far from improving the skin barrier, which is what we want an emollient to do, aqueous cream is actually damaging it. So these are the reasons why I say avoid aqueous cream. Try to guide people away from it. Sometimes people think it's nice because it has a cooling effect when you first put it on. That's because it contains so much water, it's cooling as it evaporates. Anyway, getting back to getting the best out of emollients. There are just a few things you need to know. Good application techniques, when and how, I'll come on to this. choosing the right kind of leave-on emollient, using a soap substitute or emollient wash product with the emollient, and finding out what the patient prefers. I'm going to go into each of these in a little bit more detail. Application of emollients is simple. My watchwords are frequently, generously, and quickly. And I'll just explain why. Frequently, well, really, emollients need to be applied whenever the skin is tight. And if you have dry skin, you will know when your skin is tightening up. If you can't flex your fingers or ankles, the skin is tightened. The other time, of course, is always after bathing, showering, or washing. Why? Because this always removes lipids from the skin. However mild a product you use, it will always remove some lipids from the skin, so the time to replace is immediately afterwards. How should they be applied? Well, swift, light strokes is what we recommend, which is why you've got to choose a nice spreadable product that suits your skin. We always recommend avoiding rubbing, although gentle massage is okay, but rubbing, as I say, particularly for a patient with eczema, but very often with any dry skin, it starts off itching, and then you have a problem. So, choosing a leave-on emollient. Well, sometimes, as it says in the NICE eczema guidelines, one product will do for everything. You can use it for leaving on and for washing. Dermal is often recommended for this, and that works very well for babies and young children. But for adults, you often need different products for, say, different products for face, trunk and limbs. Any woman will know you'll always use a different product on your face from what you might use on your legs or feet. You often need a stickier product on legs and feet where skin is much drier. Sometimes people need different products for daytime and nighttime. A stickier product is generally more acceptable at night. And very often with dry skin, people need different products in summer and winter. So there's nothing wrong with having several products. Sometimes it takes a while to find what suits you. What suits you in the summer may just not be up to the job in winter. People who need emollients can use quite large quantities. 500 grams a week would not be unusual for someone with eczema. Remember, applying generously is part of the process. In fact, we know that in eczema treatment, you need a 10-to-1 ratio of emollient to topical steroid. I don't have time to go into this in a lot of detail now, but this is something that we'll cover again in the workshops in the autumn. Pump containers are great because they keep the emollient clean, but tube products are also good. What's less good is a big open tub that you can dip your fingers in, because we know that some aqueous products will support bacterial growth. And it's really important to make sure patients have a small pack of some sort to carry in their car, desk, handbag, or whatever, so that they really can use them frequently when they need them. Now, this is a chart taken from a document that we expect will be published soon, put together by a multidisciplinary group. You can see here, this lists the different classes of emollient down this side, from simple emollients, humectant-containing emollients, antipruritic emollients, and so forth down here. A definition in the second column, some examples, just some examples, there are many more, and some guidance on usage in the last two columns. Now, I would suggest that you can use this to help you in several ways. First of all, one thing you could do is check your own counters and perhaps fill in some more examples down here. Perhaps work with your pharmacist to work out what belongs in which box. Secondly, if a patient has been using a simple emollient cream, say Diprobase or E45, and has found that it isn't enough, the skin's still a bit dry, you could move on to something a bit more powerful. I would always suggest, as I've said already, a humectant-containing emollient, and there's quite a list of those, such as Balneum, Eucerin, Calmurid, and so forth. These three all contain urea. Neutrogena Dermatological contains glycerin. As a matter of interest, Balneum cream also contains ceramides, which are part of the normal makeup of skin lipids. So all of these will do a little bit more than what simple emollient creams will do. Another useful tip is if itching is a real problem for patients, an antipruritic emollient can be a real help. It just makes all the difference. The antipruritic that's used in these is lauromacrogols or polydocanol. It's in Balneum Plus cream and E45 itch, and for some patients it just makes a miraculous difference. So I hope this might be able to help you to select products and help you to guide patients. I mentioned earlier that it's really important to use a soap substitute. Let me just remind you, washing with soap or harsh detergents, and that includes bubble bath, which is a dreadful skin dryer, all of these things will dry the skin out. So it's important if you're treating dry skin to consider using or to use an emollient wash product, because otherwise you're applying a nice emollient and then stripping it off with a fierce detergent or soap and undoing all the benefits. There are now quite a lot of nice emollient wash products which are specially designed for this purpose. There are also some purpose-designed shampoos, because shampoo sometimes can be the straw that breaks the camel's back here. And sometimes, this is actually for men, but men who have dry skin sometimes need to use soap substitute products for shaving to avoid drying out the skin excessively. Again, here's another chart from the same publication, just listing the two types of emollient wash products that we have around. And I've just listed a couple here, double base wash products and E45 wash, but you'll see a number of companies produce emollient wash products, and it's really important that they are emollient wash products because these, as it says here, contain non-irritant emulsifiers, the sort that won't irritate skin and won't do further damage. They look very creamy when you use them, but they will rinse away with water. They don't froth up as using their soap and bubble bath, but they do the job. And finally, many people also use bath emollients. I expect you're all familiar with Oilatum bath oil because it's been around for years. A simple bath oil deposits a layer of oil on the surface of the bath water, and that coats the patient on exit. The nice thing, if you've got dry skin and you've been scratching, is that using a bath oil takes the sting out of the water, and so it's nice to get into the bath. There are also bath oils with antiseptics in and with antipruritics, so you should be able to choose one or guide a patient towards the most appropriate one. And the last thing I've got to say is don't forget patient support groups. Patients can get a tremendous amount of support, at least the feeling that they're not alone and they're not the first one to face the problem, if you put them in touch with patient support groups. I've known patients go back to pharmacies and say, thank you, that was such a great support for me, I thought I was on my own. You can find the contact details of all these organisations quite easily on the internet, and incidentally, they have useful information for healthcare professionals like us too, so worth checking out their websites. Well, that's all I've got for you this morning. In summary, I'd have to say this has just been a whistle-stop tour and a brief introduction. Please remember, emollients protect and repair the skin barrier, and that's the #1 task in dry skin. If you can help patients, that's adults, children, and elderly patients, to find one that they like and can use on a regular basis, you'll be doing them a tremendous service, and I think you'll find that tremendously satisfying. Thanks for listening.
Thank you, Christine. That was absolutely brilliant, and I'm sure everybody who's listening in as well would think that was actually a really, really interesting presentation. I don't have any questions at the moment which are typed up, so if anybody wants to ask anything, I think, Christine, have you got a few minutes to
I certainly have, yeah.
Brilliant, okay. So if you've got anything in the meantime that you want to ask, then feel free to type them in. I'm a bit reluctant to unmute at the moment because I know there's a lot of interference in the background. But just to start the ball rolling, I've got a couple of questions, if you don't mind. Just to start. Yeah, I mean, there's questions a few actually, but I'll see if anybody else actually asks anything as well. Just a quick question: how much does dry skin actually cost the economy a year? In principle, is there any research that's been done for that? At all?
Oh, heavens, I don't know the answer to that. We have some figures that I don't have to hand about the costs of eczema treatment, but the problem is dry skin is not something that is recorded anywhere. So the answer is I don't know. We can look at, as you know, we can look at dispensing figures, but that's only a small part of it, because we know a huge number of patients with skin diseases across the board will self-treat anyway. I'm sorry I haven't got the answer.
No, I mean, I wasn't expecting one. I mean, it's obviously, I do a lot of work in GP practice and everything, and you know, practically every other patient has got a dry skin issue of some sort or another. It's just a quick, I mean, my estimate, I don't know, it'll probably be in the billions somewhere, I would have thought, but it's just an interesting thought as well to see how much roughly this would be. Really.
Your question is very good. Skin disease is a much, much bigger problem than we generally acknowledge. We know that in the most recent study, something like 24% of the population consulted their GP for a skin problem in a 1-year period. That's a staggering number. And that's only the people who consulted GPs. I suspect behind that there was an enormous wave of people who went to pharmacies and consulted, or who didn't consult at all, who just bought some products to treat their skin.
Yeah. Okay, I mean, I haven't got any other questions today. There's just there's a couple of other ones I thought just to ask as well. Why on earth is Aqueous cream still on the market then?
Oh, Japan, I wish I knew. Many of us have been campaigning for years.
Yeah.
All I can say is, you know, it's the first item in the BNS, as you know, so it's kind of easy if you look it up and think, need an emollient, oh, here's one. Plus, of course, a great many PCTs put it in their formulary.
Right.
Encourage GPs to use it. So, you know, GPs are in a bit of an awkward position being told, use Aqueous cream first, and if it doesn't work, well, I can tell you it won't work.
Right. No, it's just interesting because I thought, obviously, I used to use it myself, and after obviously we spoke before, I don't use it anymore now, but it's just interesting to see, you know, if there's any reason as to why it's still on, because obviously the better ones on the market, and generally the better ones which come out, they tend to take the NAF ones off, if you see what I mean. So
I see exactly what you mean, and many of us are completely baffled as to how Aqueous cream has maintained its place. I've just written an article for Pharmacy Magazine explaining all the scientific background to this.
Right.
And again, asking the question that you've just asked, how on earth is it still there?
Yeah. Well, there's a question that I think will be for the NHRA, I suppose, isn't it, to look at, I suppose. So, and last question again. I think there's no others at the moment which are waiting. A lot of the counter assistants here would actually see dry skin boost the first port of call for many patients. Obviously, if the skin looks infected, then something like this probably isn't going to be a good idea to give, a simple emollient. First of all, could you go over what a cancer patient should be looking for in that instance, and what the best sort of like course of action would be in that?
Certainly.
Yeah.
Now, infected eczema is often a problem. It occurs in children and in adults. And what happens is the eczema gets worse. So it's more red, it's more visibly inflamed, it feels hotter, and the skin is more obviously damaged. That's the first thing. And a patient may say, well, I've applied extra steroids and nothing's happening, or it's still getting worse, or it's spreading further.
Right.
And in that sort of situation, that really requires referral to the GP, because overtly infected eczema, where it's obviously getting worse, is something that requires systemic antibiotic treatment.
Right.
I perhaps didn't emphasize that enough, but those antiseptic emollients are kind of, how can I put it, sort of cherry on the cake stuff. They're not treatments for infected eczema. Infected eczema is a serious condition. It's kind of, I can't say ripping through the skin like wildfire, but you will know if you have eczema, your skin is getting a lot worse. It's more itchy, more inflamed and spreading, and whatever you do, you don't seem to get on top of it.
Right.
That's for a counter-resistant, that should be immediate referral to a pharmacist.
Right.
For a pharmacist, that should be referral to a GP.
Brilliant. Okay. And last question, again, before I think we're going to probably beneficial. Hypoallergenic products as well. So, what are your views on those? I mean, do they work, or I mean, are they simply just there to sell products, really?
No, I think some of them are a very good idea. I have to say, as an eczema sufferer myself, I have generously slapped on one or two hypoallergenic products and come up with a most frightful rash. But in general, they're a good thing. And if you are guiding someone with sensitive skin, I would go for a hypoallergenic product would not be a bad one to recommend.
Okay.
Having said that, proprietary products that are designed for treating eczema and dry skin, such as the products I've talked about, the ones that are coming to mind just at the moment are things like Balneum, Eucerin, Double Base, and so forth. These are, although they don't claim to be hypoallergenic, they are, from their very formulation, using a small range of unperfumed ingredients.
Right.
So, if you like, they are hypoallergenic without needing to put the claim on.
Okay, I see your point. Well, Christine, thank you very much for spending this past hour or so with us, and I'm sure everybody who's attended has learned a great deal from you, and we really appreciate your time as well. So
thank you
everybody,
for having me.
Oh, thank you. There's a couple of things just before we all sign off. This is actually being recorded. I know there's been a couple of late entrants recently, so this has been recorded, and we're going to be putting it onto the website very soon as well. So if you haven't got anything, or if you haven't actually, if you want to go over something again, I should say, then please feel free to look on the website. Another thing is that we're also doing the pharmacist webinar this evening, which is a lot more complicated. So if any of you would like to come to that, then please feel free to do so. We sent the email out yesterday, and it's going to be between 8 o'clock this evening and between 8 and 9:30 this evening. So hopefully, if you want to come along to that, by all means, do that as well. So I'm going to take the opportunity again to say thank you again. And Christine, are we going to phone? Shall I phone you after it in a bit? Or,
yeah, that would be great. Yes, if
brilliant. Okay then. Okay.
Can I
Okay.
stop sharing now?
You may indeed.
Right.
Okay, well, thank you again, and we will speak a bit later. So take care and have a good week and have a good Jubilee as well. Take